Okay. Hello, we are Carles Fabres, Víctor Martín Gorgojo, and Rocío Rovira. We are Spanish members of the new Our Spine Youth Club. Welcome to the Expert Insight series, where we interview worldwide expert spine surgeons who kindly share with their professional and personal experience with us. On this occasion, we are honored to present Dr. Pierre Roussouly, head of the Spine Surgery Unit of Centre Médico-Chirurgical Réadaptation de Massou in Lyon and creator of Smayo Company. He is one of the most prestigious spine surgeons of our century.
Thanks, Rocío. Hello, Dr. Roussouly. His studies on the sagittal plane have had a great impact on the understanding of the spine. In 2019, he published his book titled Sagittal Balance of the Spine, From Normality to Pathology, which is a guide for a treatment strategy of adult deformity based on spinopelvic parameters. He's a worldwide reference in adult spinal deformity and a pioneer in the current knowledge of sagittal plane. His countless publications on the subject have made him widely recognized as an authority within the spine surgery community.
So good morning, Dr. Roussouly. Thank you so much for accepting our invitation today.
Good morning. Thank you.
So if you accept, we will start the interview. So before beginning, could you tell us, please, your full name and your current position?
So I'm Pierre Roussouly. I'm retired now because I'm 72, and I think for this kind of surgery it's finished. And I have to turn my life differently because it's a big change. And I was head of the surgery unit in Lyon, the Centre de Massue, and I dedicated all my life in mainly deformity and in adults and children.
Okay, let's continue. Where do you come from? Are you originally from Lyon?
Yes, I was born in Lyon, and I've done all my life in Lyon, except I will tell you later. 1 year in Canada. I have the college, then university, medical school in Lyon, and my residency also in Lyon, and my career in Lyon. So I'm a true Lyonnais. But I'm shared by my family. I'm shared between my father was from the south of France, near from Béziers, Narbonne, and where they cook with oil. And my mother was from the area of Lyon, where they cook with butter. So it was a big conflict
That's
in
a
my
big
life.
difference.
Yeah.
And what do you prefer the most, butter or oil
Now,
for cooking?
for my level of cholesterol, I prefer oil.
More Mediterranean,
Yeah.
for sure. Great.
Okay. Okay.
So,
Next question was where do you undergo training? But you have explained it very well. Okay, and we'll continue with the next question. Could you briefly share with us the initial steps prior to becoming a spine surgeon?
yeah, so in France you have the residencies, and after you have it's called assistana. It's not assistant professor, but it's something like the fellowship. But you can do that in the city of your training, or perhaps outside. But so at the end of my residency, I had the opportunity to go in Montreal. There were exchange at that time between French and Quebec, and so I have the possibility to have 1 year of residency in Montreal, and I was mainly in Saint Justine Hospital in pediatric and in spine, general pediatrics, orthopedic, but mainly in spine. And it was the most part of my training in spine about deformity, about trauma. All my time after residency in France was turned to the trauma activity, cervical and spine and pelvis. So big trauma. But I know the question is coming, but I have at that time I have no mentor. My professor was very, very light and not very present. So I have to do all by myself, treat the treatment and treat myself for learning something. So it's something I take from this time is I do not depend from anybody, and so I learn by myself. I had the opportunity to go in during my at the end of my residency to go with Émile Le Tournel. I don't know if it's something somebody you know. Émile Le Tournel was the prince of the pelvic fracture at the time, and so I learned a lot with him about pelvis and pelvis fracture and sacral fracture, etc. So, and I think it's very important for a spine surgeon to have both the spine and the pelvis. All is linked. So you have to have time in your training to learn something about the pelvis, about trauma pelvis, about degenerative pathology of the pelvis, because I think that our specialty is too much specialized about that. And and sometimes we will have only spine surgeon on L4, L5.
Yeah.
That is a great advice for us.
But we will discuss that later.
Okay.
And so then after I have 3 years of after my residency, I have 3 years of assistana, and then I had the opportunity to go to the Centre des Massues, but I feel very, very light at the time. So I decided to turn back in Montreal for one month of, and they accept to train me a lot with a lot of deformity surgery. And the second time I went in Bad Wildungen in Germany with Klaus Zielke to learn about VDS and all anterior approach. It was very, very tough and active with approximately 6 deformity surgery a day. 3 rooms, 3 surgery in each rooms. So you have to learn. You may learn a lot.
Incredible, yeah.
And in 15 days, I know all I have to know about anterior approach. So, but after all, your life is a training.
Yeah? So do you think there is no one person that inspires you the most? No mentor, you said? There is no one in your career that
I cannot say that. During my residency, I've 6 months in neurosurgery, and one surgeon, Professor Sandou, was.
Professor Sandu.
I was very, very close with him. Then in the second time in Montreal, the whole team of leaders of the unit were very, very, very good with me, and they learned me a lot of things. But mainly, they give me the my self-confidence. It's very important. And because I was very, very close, and they give me the opportunity to present, so it was very important. And the third person is a professor in biomechanics, Johannes Dimne. And I work a lot with him, and he learned me a lot about biomechanics. And during 3-4 years, all the Saturday morning, we were working biomechanics.
Every Saturday?
Every Saturday morning, we were discussing about X-rays. You have to understand that the spine surgery in the years end of the years 18. I began in Saint-Denis in 87. It was a desert. Nothing. You don't know how to put a screw in a pedicle. You only know one technique was Harrington. It was changing with the CD. And the CD began in 82, 84. And they began with a strange theory. They said that you just have to turn the rod and you turn the spine the same way. This can be acceptable for the lumbar area, but it's totally wrong for the thoracic area. And so I was the very first to say, because I was working with Johannes Dimne in biomechanics, to say it's wrong, and to say to Dubousset was the prince, was the emperor of the spinal thinking at that time, huh? And to say him, it's wrong. You don't turn the spine when you turn the rod. Oh, yes, I say him. It's an illusion, but a lot of persons try to do that, and they break the lamina at with the hooks. So we have to turn to another way of thinking. And at that time, it was, as I said, my first pedicular screw in deformity take 20 minutes, one screw. Today, you put the screw 3 minutes. And at that time, we don't know where we were. We don't know where to put the screw. We don't know how to deal with the rotation of the spine. We don't know anything. So we have to learn everything. And when I arrived in the Centre de Massieu, I said, I no more use hooks, at least in the lumbar area. In thoracic area is coming later, much later. It's coming something like 2010. It was SEC that began with using the screws with a kind of, but everybody said it's too dangerous, and it stays something very controversial with pediatrics. I don't like to use the screws in the thoracic area. So you have to know that at that time the spine surgery was a kind of desert. There's nothing. We have to. We only know how to put hooks and that's it.
We realize with your words the importance of the training and also the importance to go abroad. and be connected with all the new strategy, new knowledge of Spain. And we thank you for the advice and this was. So let's continue. If you were to give an advice to young surgeons, why would you recommend spine surgery? What do you think are the pros and cons of becoming a spine surgeon, Dr. Roussouly?
First of all, we have the, I don't know in other country, but there's something, we have a big problem with the spine surgery today. Is this difference of training between neurosurgeon and orthopedics? As neurosurgeons are in France, in every city, we have a university unit of neurosurgery. But we don't have university unit of spine orthopedics. So a lot of young surgeons are training and train only with neurosurgery, without any knowledge about pelvis, about hips pathology, and about biomechanics. They know perfectly everything about the nerves, but about the bone, I don't think that. So for me, there is a big problem here. I know that saying that I will have all the community on my back, but today the whole system is turning to microsurgery, micro approach, decompression, and long fusion, balancing, reduction, understanding the different shapes and morphology. No way. The last SFCR, so French Society meeting, there were no question, nothing about balance, nothing. It's finished.
In this sense, I hardly remember when I stay in Lyon that every patient have the tele
Yeah.
X-ray.
Yeah.
And they said to me each day it's important to understand the biomechanics of the patient and the type of Roussouly in each patient before doing surgery. That means if you are in front of a hernia, discal hernia, or stenosis, you should understand or you should study the type of the spine.
Yeah, I think it's fundamental because either you say the patient, I will clean the canal, I will clean the hernia, and that's it. So I treat only the compression, not a problem. But in those patients, you have patients with, on one side, hyperlordosis, and patient on another side, very flat back. If you have only a view of 3 or 4 vertebrae, or if sometimes you have only the CT or MRI in prone position, how can you explain the patient your future? I remember a guy he was a captain in the French army, well built, a lot of sports, etc. He began the first hernia at 28, and he was a pure type 2 with 35 degrees of pelvic incidence. So this guy will have back troubles all his life, and is not done for jumping. Is not done for the war. So if you don't have the X-ray, how can you explain the patient? What's your status?
Yes.
That's a key.
I can explain the reason of your early disc herniation because of your back, because of the shape of your back. If I am only the CT or MRI or a small X-ray, I will not have any indication for this patient. I will say, oh, I removed the disc herniation. It's perfect. Bye bye, so long.
They will come back.
Yeah, they will come back. But when he come back, how can we explain? I have always pain. Now I have back pain. You may have physiotherapy and it will be okay. So go to physiotherapy. And then this during 10 years, he go to physiotherapy. He cannot understand why he's not performing in his career. He cannot understand why he has, etc., etc., etc. So we have everything on the X-ray. Another thing is that the patient is coming 5, 10 years later. You have the original long X-ray. You may say, okay, you were like that. It's a problem of your morphology. It's not only a problem of your local disc with the disease of this disc.
Yeah, it's a good advice. Okay, next question. What personal character traits should have a spine surgeon to have to become a good, well-rounded professional?
The first is listen the patient. The second is listen the patient, and the third is listen the patient. So the patient is always right. You learn your this specialty with the patient. And so first, it's very important to have a regular review of your patient. It's very important. Second, it's very important to have a personal psychological evaluation of the patient, to understand the patient. What he is expecting for? What is the relation between his status and the disease? If you have a woman 45 years old with a 60 degrees thoracic scoliosis, there's always a psychological impact. Always, always, always. So in the demand, perhaps she is comfortable, perhaps she may continue to live with that on the mechanical point of view. But on the psychological point of view, you have to understand why she's complaining, why his life is not perfect, and to understand the relation she had with the family, husband, children, etc., etc. This is fundamental. So the relation with the patient is fundamental. You have to love the patient. It's very important. This surgery is not only a matter of techniques. You may be a perfect technician, but a very bad surgeon. This surgery, it's a matter of strategy. Understand the mechanic of the patient, understand the psychology of the patient. Because if you are wrong about the psychology, if you miss the patient and you do not understand what is or she is expecting for, you miss the surgery. You will have a bad result. As a patient, I feel I feel the roads. I'm not comfortable. I was expecting something else. I think that with the surgery, after the surgery, I will have a better relation with my husband, etc., etc., etc.
Yeah.
So this is fundamental. So for the training and for the quality of the spine surgeon, clever, because it's difficult surgery. So you have to understand and to work and know why the patient is complaining after a surgery. When you see a patient with 2 screws, everybody thinks good, and is complaining pain. So you have to accept that and try to understand the problem. Then understand the psychology of the patient, and then follow your patient. Follow the patient by yourself, not by another one. I've seen so much, oh, my patient is following by the physiotherapist, it's perfect, I have nothing to do.
Yeah, that's a really good point you raised, that we have to not forget that we are treating people that have also a family, that they have their own problems, no? And so we have to listen to them and not just watch the X-ray, watch the MRI, and just go into the OR without even knowing their names, no? I think it's something that it's getting lost, no, in the new kind of medicine that they are teaching us.
Yeah, it's fundamental, and the psychology is always changing with the age. You don't have the same psychology with an ado compared with a woman 40 years old or a woman 65, because they are not expecting the same. So it's fundamental to know that. So it's in your training, you will not have that. It's by yourself that approaching the patient, understanding the patient, you progressively, but take care with this aspect of our, because I think it's totally different with the cardiologist. The heart is generally has not a big impact on the head, but you imagine the deformity, you imagine the pain when you have a permanent back pain, etc., etc. The impact on the psychology. In French, we said, "J'en ai plein le dos."
J'en ai plein les dos.
So my back is full. Okay, so and when you say that, it's not my back is painful, my head is painful.
Sí. Awesome. So could you have talked about some patients that have made an impact in your career that you remember. Could you tell us about your most challenging case of all, the one that has really changed your mentality, or like taught you something that changed the way you practice your medicine? Do you have any?
I think it's probably this case changed totally my life, because if I wasn't good, I will be fired from the center. It was the very first case in the center. So summary, boy, 14 years old, congenital kyphoscoliosis, thoracic kyphoscoliosis with an hemivertebra, beginning a paraplegia. I was 35, and I asked the thoracic surgeon if he could help me. No, I cannot. I asked the neurosurgeon. No, I cannot. So, okay, I'm alone. I have to do that alone. It was the first time I was treating this kind of patient with an anterior decompression. And I had the case of decompression with trauma, but not with an hemivertebra. Well, fortunately, the patient feel okay after the surgery. It was a success. But I think that if I miss the patient, I will be my career in Saint-Damascus will be very, very short. But I have other cases, of course. But this is the case you remember. Huh? You never forget.
It's always in your head.
Exactly.
For a case,
So coming back to the argument of the biomechanic, the study of the etiopathogenesis in the spine using the Roussouly classification is now mandatory for a proper treatment strategy. What do you think it is so important for us?
I think I give you partially the answer before. I think that first we are all different. Our morphology is totally changing with the shape of our pelvis. And by the way, we cannot offer the same strategy to different patients. And so we have to understand the reason why the patient could be painful and the mechanism due to the morphology of the patient. And then after with that, we have to solve the problem of how I can change positively the morphology of my patient. How can I restore a good balance? Or how can I propose another shape according to the current status of the patient? Because you have patient with poor deformity, sagittal deformity. He was a type 4 initially. He remains a type 3-4. So the restoration would be easier because you are close to the shape, the ideal shape. But some are totally changed with the kyphosis, with hypolordosis, and so on. And you have to change totally the shape of the patient. And that would be very challenging. First, to imagine the good shape, and then to restore this shape for the good biomechanics for this patient, better biomechanics for this patient. So this is the reason why I think that for each patient with a spine problem, we have to understand his shape. And the reason why I said for each patient, we have to propose a long-standing X-ray to understand how is what kind of back he has, and what is the mechanic of this patient. So this I think this is the final cut of the balance strategy or understanding the balance. But it's not only with a formula. Pi equals to LL minus 9. Take care when it's too much simple.
Exactly.
Okay.
Simple is beautiful, but it brings you to big mistakes.
There's much more than that, no?
Yeah,
completely right.
Yeah.
And that's the beauty of this kind of surgery also, no? And this kind of thinking and learning.
This is the beauty. It's the reason why I said you have to be smart and clever. Because it's a surgery for smart and clever. It's not a surgery for dumps.
Okay.
Another problem of this surgery is that there is a conflict in our society between something looking like a huge surgery, long fusion, rods, big approach, etc., and the economy of our health system that asks you if you can do the surgery in 10 minutes with only 1 centimeter of approach would be better. And they give you much more money if you perform this kind of surgery rather than one surgery with a big reconstruction, etc. The reason why today a lot of so-called spine surgeons propose a light surgery. You will be standing tomorrow. You leave the spine unit in 2 days, and everything will be perfect. But the spine remain in bad situation, and 6 months or 5 years later, we have to redo. So it's this is a big challenge for you.
It is.
It's not a good surgery, a good economical surgery to earn money.
But do you think that we can achieve a good correction, a sagittal plane correction with MIS?
When you have surgeon unable to perform a good reduction with an open access, you think they may better with MIS. Another thing. When you take a gun, you shot somebody, the bullet, the point of entry is very small. But the disaster inside is not so small. So the so-called mini access is just the skin. Sometime I can show you some pictures of double scares instead of one regular double incision. It's really ugly, and below the muscles are totally destroyed by the root of the road, because you pass the road and the muscles, you do that inside. So I think mini access for one level, 2 level is okay. For anterior approach for cages is okay. So I defend the olive access. It's very convenient. With this access, without damaging anything, you may perform 3 level cages, it's good. But for a girl with a scoliosis and mini access, if you have a bad result, it would be really a bad result. And the problem is that you need to do the revision by yourself. But when you complete a disaster first and then after you make a revision, it's totally different.
That's so true.
I agree.
And in this sense, the Professor Roussouly, we have talked about many things, but what do you think are the current gaps of knowledge that we are still not sure or that we haven't discovered yet in spine surgery? You think there's still a lot of to discover and research about, for example, sagittal alignment, or we have everything covered already? What is your feeling about this?
I think that my dream during all my life, today doing the surgery, a proper surgery, doing a quite good reduction with a short surgery. You have to know that I think Rossio has seen that the deformity may be done in less than 3 hours. You remember, Rossio? Huh?
I can remember it.
Yes. So it's possible. 10 hours, perhaps it's too much. But our big problem now is to be sure to have a good fusion. And ideally would be to have a quick fusion in less than 10 days. That would be ideal. Because you avoid all the big complications we have after this surgery. Limitation of activity, stability, risk of pseudarthrosis, etc., etc. And I think that my dream during all my career was, if I had something, a kind of stick I can put behind, and the patient is definitively okay, stabilized in a good positioning, that could be a good thing. After aging people, we have the strategy for a patient, 80 years old patient. We may have the strategy, but unfortunately, this kind of surgery could be difficult for this patient, and we don't have a good solution with long fusion, and sometimes we have to forgive those patients with a brace and without a good option. So this is we are more and more efficient, but remains the problem of the stability of the instrumentation compared to the time of fusion and the quality of fusion in older patients. Then after, another thing is that I'm not fond of keeping mobility.
You're not fond of it?
I think that I've seen so much patient with a good fusion, long fusion, with a perfect life in sport activity for youngers, in social life for olders, that we have to do what we have to do. A shorter fusion with a bad alignment, coronal or sagittal below, the patient will have trouble later. Well, of course, during 10, 20 years could be good, But when you fuse a young girl at 14 and you are expecting that at 40 she will be okay, and not with an evolution of the spine below. And they will have the evolution. Because I've seen that all the patients with all construct, Harrington and so, well balanced, no problem. Bad balance, big problem.
Big problem, yeah.
And revision later.
Mhm.
Revision is extension to the fusion to the pelvis. So deformity is in the lumbar area. I have to fuse the lumbar area, the minimal I can, but I have to fuse the part. So this is it's very important. And keeping fusion with the tether, I'm not very convinced, but perhaps for some indication about patient with growing patient at the end of the growth, perhaps could be interesting. But about the final result, take care. You're young. You will see the effect of the tether in 10, 20 years.
Mhm.
I can guarantee you that we will have problems.
Okay.
So the next question is in the same way. What do you think could be left behind in spine surgeon? And in this sense, do you think fusion surgeries for sagittal malalignment will be the gold standard in the future?
I don't know. I don't know because uh, it's not all the theory I defend are not fitting with the sense of history. As I said, the sense of history is today is shorter, smaller, and shorter in fusion, shorter in time, smaller, based on the neurological troubles, decompression, microscope, and so and so. So this is a neurosurgical evolution. The fusion, the long fusion and correction of the deformity is something very demanding for the surgeon, for the unit, big organization, and for the patient. And it's not simple. And perhaps you treat the deformity, but I think the number of surgeons involved in this area will be less and less. And I imagine that all all the theory I develop about balance, so combined with long fusion, are perhaps decreasing progressively until the time where the short fusion will be insufficient.
Okay.
So you treat the patient with a short fusion or a short treatment, and 15 years later, he's coming, falling down. But the problem is that do not expect too late, because if you expect treating the patient at 80 years, we will have big troubles. If you have the courage to treat the patient at 50, would be better for the patient and for you.
Okay. Okay, we should keep in the biomechanics and orthopedics side in front of the non-invasive on the other ways. So
And the patient and the politics, they like mini. Less
At the short term is
expensive, less
better, no?
time. And anyway, if the patient is complaining after, it takes time. You have the story of the disc prosthesis. I've seen the very beginning. Then I've seen the expansion. What time it was? Yeah, we have the solution for everything. 3, 4 levels of the disc prosthesis. The patient is fantastic and so on. So then 10 years later, the results are so bad that it's like, hello, Houston, we have a problem.
Okay, so we are approaching the end, Professor Roussouly. So we would like to ask you 2 more questions. So coming back to your career, what do you think is the achievement that you are most proud of? Is it your classification? Is it your patients? What is your
So
thought?
I have to say you that I cannot be proud, because in science you have to be humble. And so I can give you a metaphor. Religion in religions. You see you have the prophet. Prophet. How do you say that?
We understand.
Yeah.
The prophet is somebody who spoke. Even better, I've seen God. So, but he's the only one to know that. Is it true or not?
Yes.
And disciple, how do you say disciple? I don't know.
Disciple.
They are sure 100% he has seen God. So for the researcher that opened a door, he cannot be convinced it's true. He has to be humble, because the science, it's a permanent evolution. And perhaps this will be the answer for the next question between research and teaching. And so you may be proud because you have some honor. Very few. Honestly, very few. Now I'm retired. I don't have any contact with somebody about research and so on. Donc, so we have to be humble, and probably somebody, you, Rosso, etc., will change everything with a new concept, but you were there. So it's something. The concept for the moment is complicated, is not accepted by everybody, and there is a lot of controversy. That so sometimes you think perhaps it was a mistake, perhaps I don't explain that very well, or I may understand why they not understand, etc., etc.
Thank you for your answer.
Yeah. On the last question, if you could turn back time, what advice would you give to your younger self?
Sorry, give.
Yeah,
I
I repeat. Yeah. If we could turn back time, okay. What advice would you give to your younger Pierre Roussouly?
If I have to redo my life, I have a very good life. I'm not proud of what I've done, but I'm proud of my life. I have a very good life. I have a good family, I have good sons, good girl. No way. So I'm happy with my life. But to say that something is more important, you will see the life is changing every time, and then progressively, you something was very important is becoming less, and another thing appear more important, and so it's a philosophy of the life. So you're too young to know that, but you will have the experience. I wish you that.
Okay.
Okay. To end, let's engage in a quick game in which we ask a question and you reply with a quick and fast answer. So, a hobby that you enjoy doing it? A hobby?
Hobby? I have several because I'm eclectic. I cannot have only one activity. It's impossible. So first, I prepare the answer. First, cooking,
Okay.
oil and
First
butter.
cooking. And your favorite book?
Ah, I, I read a lot, and I cannot find one. That one of my favorite authors is Émile Zola.
No,
Okay.
Favorite sport?
Sport. So
Okay.
I'm not sportive because I'm a type 2 plus scoliosis.
Okay.
So I failed in every sport. So I'm a TV sport.
Okay.
Very
Right.
different.
Watching it.
So TV sport, from my origin, south of France, I'm rugby.
Okay.
With my son, I'm football.
Nice. Okay. Thank you.
Uh, Favorite surgery?
Favorite surgery? Um, the most difficult, I think, the most difficult, high-grade spondy.
Spondy. Oh, oh,
High-grade spondy.
oh.
I agree.
Yeah.
This is the most difficult.
Okay.
Good surgery, very efficient, regular, good result, adolescent scoliosis, idiopathic scoliosis.
Okay.
Navigation, Professor Roussouly, or freehand?
Ah. In lumbar area, I recommend, so I never use navigation because my hospital was missing money, so no navigation. So I use the image intensifier. I use the image intensifier with an AP view. AP view.
Okay.
I try to teach that to the way they do not understand anything. They don't want to use that. But AP view show you everything you want. So in lumbar area, till T10 with the image intensifier, in thoracic area, freehand. We are speaking about the screws. Huh? Because in thoracic area, the anatomical landmark is well fitting with the place of the pedicle. In lumbar area is different. Take care.
Okay.
Okay. Another time, open or MIS surgery?
Of course, open.
Okay.
But as I said, I describe olive surgery. I have the first paper with olive surgery. It's a mini-invasive surgery. So when it's mini-invasive is efficient and useful for your surgery, take the mini-invasive.
Okay.
But not for everything. I think for scoliosis, no.
Okay.
We got it. And a word that defines spine surgery? One word.
One word, smart.
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 Okay.
So this has come to the end. Professor Roussouly, thank you so much for joining us and having the chance to have a conversation with you was really a privilege for all of us and for all the people that will watch this video just after the interview. We are going to publish it and we will try to share it with the members of our new youth club from the US Spine. And so thank you so much. It was a true privilege. Thank you.
Yes.
Yes.
Thank you for your welcome and your question and your youngness.
C'était un
Thank you.
vrai plaisir de vous écouter, professeur Roussouly. Et pour nous, on espère d'avoir transmis notre motivation et un peu notre sí, motivation pour la chirurgie du rachis. Alors, merci beaucoup. C'était une conversation très amusante et très stimulante pour nous. Et encore merci et cordiale salutation.
Merci à tous.
Thank
Au revoir.
you.